afternoon, everyone. Welcome to today's webinar from the Care Quality Commission. It's really nice to see so many people join us today. We've got a few people still joining us, but to make best use of the time, we're gonna make a start. So just to quickly introduce myself first, my name's Sam Wallace. I'm Provider Engagement Lead here at the Care Quality Commission. Great. I'm going to bring in our two key presenters today to introduce themselves in a second, and they're going to be talking through most of the content today. So Amanda, can I go to you first to introduce yourself?
Yeah, hi everybody, I'm Amanda Hutchinson and I'm the Head of Policy for Regulatory Change. I've been working on the development of the single assessment framework and new regulatory model with a number of colleagues.
Okay, and then over to Dave.
Hi everyone, Dave James. I'm the Head of Adult Social Care Policy, but I've been working closely with Amanda on the development of the model and the single assessment framework.
Yeah, fantastic, thanks both. So before we get into Amanda and Dave's presentation, just a little bit of housekeeping to cover off, just so we can make sure today's session goes as well as it possibly can. And I'll start with a bit about how today is going to run. So for those of you who've been to our webinars before, you're probably quite used to the experience, but there might be some new people here. So because there's so many people joining us today, we use something called Teams Live Events, which means the only people you'll be able to hear are myself, Dave and Amanda, but you are able to participate and we really want you to participate, and you can do that by using the Q&A functionality that you'll see at the top of your screen. So if you have a question or a comment as we run through today's session, please drop it in there and we'll be looking at that and collecting all that information today. We're going to try to do our best to stick to time in the presentation, primarily because we want to leave as much time for questions as possible. We did ask people to submit questions in advance of today's session, and we're going to be prioritising answering those, but we will have time to come to questions that you drop in the Q&A as well, so definitely do that. We do want to make sure that we just focus on questions that are quite relevant to today's topic though, so we'll also be prioritising those. But we'll also be prioritising those questions that are most popular. So if you see a question in the Q&A you really want us to answer, you can give it a thumbs up. And when we get to that part of the agenda, we'll look at the ones that have got the most thumbs up and come to those first. Just also to flag that we are recording today's session and it will be posted onto our YouTube channel after today. So you can watch it back or share it with your colleagues if they're not able to attend. And we'll also share all the slides from today after the session. Just to really quickly flag who else from CQC is here. So there's a few of my colleagues in the background who are going to be helping out. So Steph and Abigail are helping to produce today's session and make sure all the tech runs smoothly. And also my colleague Ed is going to be active in the chat today and trying to answer questions as they come in as well, if we can offer a really simple answer. Great, so a quick note about what we'll be covering today in today's session. So a couple of weeks ago, we published some new provider guidance that's related to our new regulatory approach. So this was guidance around quality statements and evidence categories. And what we've tried to do is really show what we've tried to do in that guidance is really show the kind of evidence we'll use to assess different quality statements for different types of providers. So today's session, we're going to talk through this guidance, what it covers and how we hope it will support you to understand this part of our new regulatory approach. We know it's important to get this guidance right, so we are looking for your feedback today and through a survey that we'll share with you to help us refine this guidance. So after Amanda and Dave talk through this, we'll have time for questions and comments. As I said before, we'll prioritise the ones we received in advance of today's session, but we will have time to come to those in the chat. So that's what we're going to be covering today. We hope today's session is really useful. And I'm now going to hand over to Dave, who's going to take us through the first part of the presentation.
Thanks very much, Sam. So yes, I'm going to talk about the quality statements and the evidence categories and just bring those to life for you a little bit. So you may well already be familiar with the kind of the high level view of our single assessment framework. The 5 key questions remain. So we're still asking if providers are safe, effective, caring, and responsive, and well led. But in place of our Chloe's and our prompts, we've got a different structure. So we've got our quality statements, which are essentially the standards that providers, but also local authorities and integrated care systems will be assessed against. We have set out 6 key evidence categories, and I'll go on to explain those a bit more in a moment. And beneath those layers, we have the really more specific material that sets out exactly what good looks like within a certain type of service, within a certain type of sector. And this is a key part of how we make sure that ratings are up to date, and to give us greater insight into strengths and weaknesses across the health and social care system, as well as providing greater transparency to providers as to what's supporting our rating judgments. So yeah, I mentioned the quality statements. Hopefully you've had a chance to look at them on our website, but do please spend the time looking at those. These are essentially, they're written as we statements, so kind of calls to action essentially. And these are our commitments that providers and commissioners and system leaders ought to make to live up to high quality and person-centered care. They are mapped to the regulations as well, so it's clear kind of how the legal minimum that guides our work relates to good, and that's the key thing about these quality statements. They're expressed at the level of good, and then when we apply our scoring, we can measure kind of variance from that benchmark of what good looks like. And people there, depending on the type of assessment we're making, generally it will always mean people, of course it will mean people that use services and families. It will also, for some of our other assessments, for instance local authorities, that will be looking at the experience of unpaid carers, for example. So the next slide please. And then evidence categories, I mentioned there's 6 of them. This is how we're organising our judgments and our assessments. Now these are drawn from the key lines of inquiry and the prompts that are in our current approach. And if you've heard us speak about these before, you'll know that there's actually a lot of those. There's over 300 of them, which we don't think is optimal for anybody's needs. But what we found in kind of looking at that approach and understanding how we can improve, we've found that we're basically asking the same 6 questions over and again, and that is what those evidence categories are. So what's people's experience? What have we observed? What have we heard from staff and leaders? What have we heard from system partners? What can we understand from processes and also from outcomes data sets? And the other key change I think that we are wanting to make in our new approach is that we're being much clearer on how much is enough. So both for providers but also for our inspection teams, setting out what the key evidence categories are. So it won't always be the case that all 6 are necessary to support a robust judgment, and that's some of the information that we've put out, which Amanda will speak about in a moment. I think I'm handing over to Amanda now actually.
So I'm going to talk in a bit more detail about the evidence we'll be looking for and using to make our assessments. If we could move on to the next slide, please, Steph. So we've published new provider guidance on our website, which shares more detail on the evidence we'll look at during our assessments. And as part of that, we've shared detailed descriptions of each evidence category, and also the detail of what evidence we'll look at against individual quality statements and for different types of service. And we've shared a link to this guidance with you ahead of this call, and we'll be sharing in the chat now. So what we've put together enables you to drill down for different types of service, for different quality statements, for different evidence categories. What are the sorts of evidence? What are the types of evidence that we'll be looking for when making our assessments? Now, we're publishing this information in draft, and what we're doing is gathering feedback from providers on the detail of what we've published, and we'll improve it following feedback that we received today, and also through a survey we've shared with providers, and we'll share again with attendees. We're testing different levels of detail. So for some types of provider, we've shared the broad evidence categories. And for others, we've also shared example types of evidence under each category. And we'd like to understand what level of detail works best for you before we produce the final guidance. And our aim is for the final guidance on this topic to give you the information you need to understand what we're assessing in your service, the evidence we'll use to arrive at our judgments, and hopefully it'll help you feel prepared for our assessments. And where appropriate, we'll help you align your own quality assurance processes with our approach. I think in saying all that, though, I think it's really important to stress that in sharing this information and this level of detail, what this is a kind of tick box exercise of the evidence we require. It's not the case that this is about preparing a portfolio of evidence for CQC, and that if you've got that portfolio of evidence, you'll pass a CQC assessment. It's absolutely about, this is the sort of information that we will look for. And these are the sorts of things that we'll be looking at in making our assessments and judgments. And we will be applying a level of judgment through our scoring process to that evidence that we find and that we collect from all sorts of sources. So just to give a bit more of an example of the type of information we're sharing in the new guidance, and this is setting out for an individual quality statement around infection prevention and control. So for individual quality statements, we'll share the categories of evidence that we'll use when assessing this statement. And if helpful, we can also provide examples of the types of evidence under each category and share this for different types of providers. So on the screen, you can see that for this particular quality statement, there will always be 4 categories of evidence that we'll look at. So when we're looking at infection prevention and control, we will always look at evidence in the categories of people's experiences, feedback from staff and leaders, observation and processes. And that sitting underneath that, we've given several examples under each of the sort of evidence that we'll look for. But I think it's, again, really clear that these aren't exhaustive lists, and we might look at other specific types of evidence, and obviously that will be tailored for different types of services. But for example, if we're looking at people's experiences, we'll want to look at evidence give feedback on care. In a GP surgery, we'd want to look at the GP patient survey. We'd also want to look at any surveys that the provider has conducted themselves. Under feedback from staff and leaders, we would want to have conversations and interviews with staff. We might look at whistleblowing information if there is some available, and also look at, again, any staff questionnaires that the provider has produced themselves. Observation of care, we might observe staff in practice in the practice of care. So for example, hand washing, PPE. We'd also look at the environment and look at equipment. And then under processes, we might want to look at any audits that have been carried out, kind of what the referral processes are, and also management of test results and clinical correspondence that might tell us something about what the processes around infection and prevention and control are like in a particular setting. And then if we could move on to the next slide, please, Steph. And this is how the information could be displayed on our website. So again, this is setting out an example of a specific quality statement, and the evidence we'll look at when assessing care homes and supported living services around safe systems, pathways and transitions. And as you can see, there's the specific quality statement at the top, followed by the evidence categories and example types of evidence. And as Dave said, this is all about supporting consistency in how we're conducting our assessments. It's about being as transparent as possible about what we're looking for, and it's also to help providers think about their own practice, and also thinking about best practice in these areas. So that's what I was going to say on the detail around the evidence categories. I think it's back over to Sam now.
Thank you, Amanda, and thank you, Dave. So we've come to the part of the agenda which is for questions from yourselves and to hear any comments on what we've shared today and shared through the guidance already. I think a big part of why we wanted to have this conversation today is, as Amanda said, so we can get feedback on the guidance that we've already published to make sure it meets your needs. So we did ask for some questions in advance that we'll come to in a second, but if people want to ask anything in the chat, in the Q&A, or share any comments there, please drop it in. We're particularly keen to hear whether the guidance we shared gives you the level of detail you need to understand how we'll assess against the quality statements, whether it's more helpful to just provide the broad evidence categories or to add that extra level of detail to share specific examples of evidence, what else we could provide to improve the guidance, and what questions you might still have about quality statements and evidence categories after reading the guidance. So as we're going through the questions that have been submitted in advance, do drop them in the chat, any other questions in the chat, and like the questions you'd most like us to answer. We probably won't be able to get to everyone's question today, but just to kind of reassure that we do take everyone's comments and questions away, and it helps inform how we develop the guidance going forward and information we share through our email bulletins and in future webinar sessions. So I'll come to the questions we got in advance. Just to say, I know a few people did ask about when we'll be sharing information like this for types of providers we haven't shared yet, and we are aware there's a couple of sectors, like some independent health sectors, we haven't yet published this guidance for, just to reassure people that over the next couple of weeks we will be adding that additional information. But I'm going to come to Amanda for the first question, and we had a question asking that if a certain evidence category doesn't fall under a quality statement at the moment, does that mean that type of evidence will never be considered for that statement, or is there still a chance that it might be?
So what it means in practice is that we won't routinely look at that type of evidence at present, but one of the things that we will be doing is learning and iterating our approach. So if we find that in practice a particular evidence category is actually something that we're needing to pick up on a regular basis, we will change that in the future. And I think it's also important as part of this that we will have a kind of obviously a regular process of flagging to providers that the changes that we have in the pipeline to the assessment framework, to give people an opportunity to prepare where we are making changes as we improve and iterate what we're doing.
Thank you, Amanda. The next question I'm going to go to Dave for. So a few people noticed that we didn't always list outcomes as an evidence category for some types of services, particularly some in adult social care. So there's a question about why that was and whether that meant we weren't as interested in outcomes for some of those types of services.
Thanks, Sam. Yeah, I can understand the confusion here. So this is really outcomes with a capital O is how I would put it. So essentially, that is where we've got consistent and nationally available data sets. And in sectors such as social care, we don't have that. So it's things like mortality rates, readmission, emergency admission to hospitals, vaccination data, prescribing data, and so on. It's those big national data sets. I think in a sector like adult social care, it's outcomes with a small o that, of course, we're interested in, and that would be, for instance, people's experience of care and their satisfaction with the level of care they're getting. That said, if providers do feel they've got other forms of outcomes that they want to share with us, absolutely, that is absolutely great and welcomed. It's just that for how we've structured our evidence, the definition we're working to is, as I say, outcomes with a capital O, and it's those big national data sets that at the moment, at least, we don't have in sectors like social care.
Thank you, Dave. So the next question, I'm going to go back to Amanda for this. So I think people have heard on previous webinars us talk about prioritising, looking at some quality statements over others, and we had a couple of questions to ask if we could say a bit more about that and whether that's still our plan.
Yeah, so obviously one of the things that we've had to give some thought to is how we make sure that in our assessments we're not just following the risk, that we're not just responding to information of concern that we might have, but that we're actually able to proactively assess all providers on a regular basis to make sure that we are capturing where services are improving, as well as where there are concerns about quality. So what we're looking at the moment is prioritising a kind of subset of quality statements that will be the kind of minimum scope for an assessment, a routine assessment of all providers over a period of 1 or 2 years. The thinking is that we tailor this to different types of service depending on our understanding of kind of what the particular issues are for a particular service, and also to stress that set of priority quality statements, that is a minimum set. So our assessors and inspectors will be able to widen out the scope of an assessment at any time. But yes, that concept of a set of priority statements that we'll identify and publish is very much part of the thinking at the moment.
Thanks, Amanda. And just emphasise that published part of the answer. So we want to be as transparent as possible and let providers know what those priority quality statements are as soon as we have them. So Dave, over to you next. So obviously we've talked about one of the big moves in our new regulatory approach is moving from the CLOEs to the quality statements. So we've had a question about whether we've put together any mapping that shows which CLOEs the quality statements replace.
Yeah, we haven't pulled that together, and as you said at the start of the webinar, Sam, we're really interested in understanding what would help in terms of the guidance we put out there. So we're really keen to get views on this. One of the key principles for the single assessment framework was addressing the duplication issue. So in pulling it together and starting to map it out, we essentially looked at the topics that CLOEs were covering, and then looked at where the best home might be for the 5 key questions. I would hope that that those on the call and others that look at our approach can see how we've moved, how topics have moved, and how we've made it clear, for instance, how caring is distinct from responsive. You should hopefully be able to see where things now sit. And there are a couple of new areas such as workforce wellbeing and environmental sustainability, for example. But for the most part, I'm hoping that transition is quite clear. But as I say, we're really keen to just hear from yourselves what would be helpful as we make this transition to the new approach. So do get back to us on that.
Great, thanks, Dave. So the next question, and this is back to Amanda. So would CQC consider the introduction and publication of a hierarchy of evidence? So I think there's a question here about whether all our evidence categories have the same value, but also I think there was an add-on to this question about how we use evidence to support other evidence to make sure it's accurate as well.
Yeah, so it's a basic principle that all our evidence categories are equally weighted, and I think this is a kind of really important principle coming from when we developed our strategy, that's around making sure that we give the right sort of weight and value to information that we hear about people's experiences of care. But what we will do, which is as we do already, is explore whether evidence is supported by other sources. So there's absolutely still that principle of triangulation as well between evidence categories and sources of evidence. And also all of our judgments will go through a quality assurance process. We have identified that there are some probably quite exceptional circumstances for certain quality statements in certain sectors where it might be that the way the evidence is scored and brings together the overall quality statement score is counterintuitive to kind of one piece of evidence that's sitting within that quality statement. So, for example, that might be a piece of evidence about clinical outcomes that is clearly at odds with what people are reporting about their experience of care. So we have introduced a kind of moderation step that's available in those circumstances for teams to kind of revisit that score and make sure that it does kind of make sense in the wider world. But when that happens, it will be really clear that we've done that, and we'll also be asking our teams to be really clear what the reason is for having taken that moderation step and adjusted the score.
Great. Thank you, Amanda. So over to Dave for the next question, which I hope will be quite a simple one and quick one to answer. So if a service operates under the regulated activity personal care, but has the service type home care and supported housing, which set of guidance would apply in relation to the evidence categories? Would it be the home care guidance?
It would, yes. And just to quickly explain assessment service groups, that's essentially the level at which we rate and report. So at the moment, many of you will be aware that, let's say, for instance, there's domiciliary care in a care home at the same location. All of our judgments, and there's one report, everything is kind of bound up under one rating, which doesn't really do a service to that service, if you like. So home care and care homes, for example, are going to be separately rateable entities in our new approach. So, but yeah, to that specific example, yes, it would be home care.
Thanks, Dave. And so next question, back to Amanda. So this is one that's definitely related to how can we make the guidance more useful to providers? So we were asked, will there be a downloadable, i.e. PDF document that contains all the details now present on the website? So the question explained that local organisations will be creating a document through multiple copy and paste efforts otherwise. So suggesting this is a very simple way the CQC can assist all providers.
Yeah, so there is an option of downloading individual pages or the whole set of pages as a PDF document that can be printed or saved. It's worth remembering, though, that guidance is periodically updated, so it's helpful to always check back to the website for the latest information. But yes, a PDF document can be generated.
Thanks, Amanda. And I think feedback like that is really, really helpful for us as we think about developing other forms of the guidance we can share with providers. So we're giving it to you in the format that's most helpful. So Dave, we've got a question around one of quite a new quality statement for us, which is around environmental sustainability. So I think there's a recognition this is quite a new area for us in terms of our assessment, and just a bit of a question about what are the next steps in this area. When do we think we might be able to share more information about how we're approaching looking at environmental sustainability?
Yeah, sure. So we've put the high level material out there, which is the evidence categories, feedback from staff and leaders, and processes. What we'll be doing over the coming weeks for all service types is building out the detail at the lower levels. So kind of what's the nationally recognised best practice for each of the quality statements. We're developing that material, and we'll be publishing that. And for this example, I think the best practice probably already exists, and it probably would be the NHS produced material. But we want to make sure that we're producing a comprehensive set, and so that providers are clear on what it is that we're having regard to in terms of the best practice standards and guidance that sit, as I say, at that lower level of detail for each quality statement.
Thanks, Dave. I think we might be sticking with you for the next question as well, which is around I statements. So another new part of our assessment framework. So just asking for a bit of clarity about how these fit in with quality statements, and where we've kind of positioned them in the guidance we've shared.
Sure. So hopefully you've seen that these are on our website now, and they're mapped to quality statements. Really, these were the starting point for how we built out the framework and how we started from that person-centered approach and using that authentic voice of people to then build out to the standards that providers and commissioners and system leaders would need to live up to. But it's also fair to say there's more work to do, more enhancements for us to do as we bed in this model, and that will be around how we use those I statements to really understand people's experience, and when we're engaging with people through a different means, that they're likely to have a very strong role in helping us understand and helping people understand, crucially, what it is they should expect. So for the time being, they're essentially they're essentially really magnetic north, I suppose, for our framework, with the quality statements being the compass. So they're certainly very valuable, and I would commend everyone to be aware of them and to be thinking about to what extent your service is delivering against the expectations that people have articulated in those I statements. And just to reiterate, they're not CQC material. That's material that's come from people that use health and care services themselves. But we will be doing more work to, for instance, develop I statements that work for well-led, but also to develop an approach as to how we can use this to really understand people's experience. And we'll be certainly doing more engagement and developing that approach with providers as we start to do that work.
Thanks, Dave. So there's one more question we'll take from the questions that were submitted in advance. So this is again about a specific quality statement area, particularly trying to understand what evidence we might look at when looking at safeguarding approaches in a provider. So I think, Dave, I might be coming back to you again for this one.
Yeah, sure. Yeah, this goes back to the point on that wheel, where I was explaining that at that lower level we need to tailor what this actually means, what the high level quality statement means for different contexts, different service types, and in this example, a provider assessment versus a local authority assessment. We have published that lower level of detail for safeguarding in our local authority assessment framework, so you can see how that looks on our website, and that's the work we'll be looking to do for assessment service groups as well, for those different types of services that in our provider role. So again, as we start to publish that, you'll see the more specific material that sits under that. But as I say, you can see that at the moment for the local authority approach and see what's covered there.
Thanks, Dave. So just to say, we did have other questions submitted, but they were more around other topics rather than the one we're discussing today. But I just want to reassure people that we're not losing those. We will be having future webinars to cover other areas of our new regulatory approach. So those questions that you sent in to do with those areas will go forward to those webinars, and we'll answer those in those sessions. But I think we can go and have a look through the chat now and try to pick up some questions there in the time we've got left. And if I go to the most liked one first, so we have a question that says, when will there be more detail on what specific evidence requested for specialities and what constitutes scores of 1 to 4, so providers can benchmark themselves against this? So I think the first part of that question we've probably covered off today. That's the guidance we're talking about, where we list the evidence against specific quality statements. But the second part of that, asking for more information on our scoring approach. So I know we have got some information on our website that talks about that, and we'll make sure we send that out to attendees. But it might be that providers feel like we need to share more information. So we'll also ask you for your feedback around that. But Dave and Amanda, is there anything you want to say on the scoring approach, just to give the kind of headlines of what that looks like in the new framework?
So as you said, Sam, there is some detail of that we published a little while ago on the website, and I think that really sets out basically the 4-point scale that we'll use and the kind of high level one-line description of what that score means in practice, and it's very much about what the evidence tells us in terms of performance, rather than giving a kind of detailed quality by quality statement set of what we used to call characteristics of ratings around this. As Sam said, I think we're open to people suggesting whether there are further levels of guidance that might be helpful, but I think it's about kind of getting the right balance between guidance that will help people versus guidance that would just need to be so detailed across all of these different quality statements and evidence categories and assessment service groups that it's just impossible to sustain. I don't know if you want to add anything, Dave, around the kind of thinking around the ratings characteristics. I think they are something that when you actually get underneath what's in there, well, I'll let Dave just talk a little bit more about yeah.
Yeah, thanks, Amanda. Yeah, we did quite a lot of work over a number of years, because the single assessment framework really was built up from everything we heard from providers over a number of years, and added to our body of knowledge and an understanding of how effective they were. And the ratings characteristics is certainly an issue that we wanted to tackle. That we're not wanting to recreate that approach, as Amanda said. To do that properly would be such a vast amount of text, and that's really what we want to get away from. We want to make the framework accessible to all, and to be concise. Really, if you look at the ratings characteristics, taking the starting point of good for any particular part of our current framework, what you then find is requires improvement is essentially the same, but it will use the language of sometimes, or not always, or and also that there may be regulatory breaches. Moving down to inadequate, these things are not happening, and there will be at least one breach. And then on the other end of the scale, for outstanding, there's particularly creative things. The providers going that extra mile to deliver really good person-centered care. It doesn't need to be the huge things that happen there, but it's just we're seeing something particularly good, particularly creative, innovative, and really those are the principles that drive the 4 levels of scoring. But we're taking as our benchmarking point, as our central point, is this is what good looks like. How far away from that, positively or negatively, is the evidence that we've gathered and that we're looking at.
Thanks, Dave. Thanks, Amanda. So the next most popular question is just I think asking about the level of information we're able to provide around evidence. So I think they're feeding back that the information we shared today feels very high level, and they would really like to see some practical examples for each care sector. So I think Dave and Amanda, you might want to talk to this, but I think what we've tried to do with the guidance is share a really good idea of the categories of evidence we'll collect to assess each quality statement, and then some examples of what that looks like. But we don't want to be really prescriptive about all the evidence that could be possibly used in an assessment. Would you agree? Is there anything else you'd like to say on that?
I'll come in first, and then Amanda might want to add. I think it's just worth making the point that we're not changing wholesale the amount of evidence that we expect to see or that is even available. This is really about how at the top of the tree, really, we're setting ourselves up to provide a better service to the public and to providers in terms of how we structure our assessments, being more clear about what evidence is really important for a topic and what we don't necessarily need to cover, so that, again, providers are really clear on kind of how much is enough, and also our inspection and assessment teams are. But really, your experience of inspection and the types of things that sit under those headings, that's still the same material that's available. It's just that we're now being more organised, and it'd be, perhaps if people have got views that the way that we've described those evidence categories, it's not clear to you how the evidence that you would normally be expecting to give to us for the CLOEs, how that would now align to an evidence category, then please do let us know. But really, that bottom layer, it won't be fundamentally changing. We're just being more clear on what it is that we will look at and what we don't need to look at necessarily for each quality statement. But Amanda, I don't know if you want to maybe add anything.
No, not particularly. I think it's just coming back to the point that these are examples of the sorts of things that we will look at, and it can never be definitive. And this isn't about presenting you with a checklist of things that we would expect you to have, because ultimately it's about quality, and it's about improvement, and it's about providers themselves kind of understanding and having that sense of what good quality care looks like. I think, as Sam stressed, there's lots of opportunities now to kind of just feed back on that level of information that we've shared and the best way to present that. And we just really look forward to kind of hearing some more detailed views on that through that questionnaire and feedback after this webinar.
Yep, absolutely. So next question, how will you ensure that inspections are consistent across the board and that there is no bias, as there has been much inconsistency in the past and it is solely dependent on the inspector you get? I mean, this is obviously quite a big question, and we know this is a question we get a lot. I think it's fair to say one of the big drivers for the way we've set out the framework with evidence categories against quality statements is to partly aid consistency.
Yeah, that's absolutely right. I mean, however you look at it, it's sharing more information and in a greater level of detail than we have before. And part of this, it is about being clear what we'll look for, but also making it clear that, there is a level beyond which we're not expecting inspectors to go in terms of chasing up the kind of evidence that they're looking at. I think the other thing about the consistency point is also that, the way that we've changed the way we're organising our teams into integrated assessment and inspection teams, that we have those two roles of assessor and inspector, that we've got quality assurance around that we've got a much kind of greater sharing of the responsibilities within a team. I think all helps with I know that the worries that some people have and the sense some people have that you can get an inspector with a particular issue that they always like to follow up, and I think the changes that we're making around our teams, I think, will really support that, move away from that, and introduce consistency.
Yeah, and if I could just add to that, the really important role that scoring can play in that quality assurance as well. It gives us, at the moment, the lowest level of quantitative data that we get is the rating at key question level. So that really doesn't shine much of a light either for providers, but for ourselves as well when we're wanting to quality assure and understand our consistency. It's not detailed enough. But now we'll have scores at quality statement level and also evidence category level. So we can look across for a type of service regionally or whatever way we want to slice and dice it, and understand what are the differences, what are they down to, are they understandable, or is there something happening here which is actually driving an inconsistent approach, and then we can tackle it. So we're giving ourselves now the much better tools to improve that key issue of consistency, which we know is so important to get right.
Yeah, thanks both. So the next question, if providers are not being asked to compile evidence as such for CQC inspections in line with the CQC quality statements, what precisely is the expectation around data collection for such inspections? So I think we maybe needed to do a better job to explain some of the ways in which we'll collect evidence. I think it's fair to say we're definitely still doing inspections, and definitely that will be a key method for collecting evidence, but it's in the new framework, it's one amongst a few methods rather than being the sole one going forward. Dave or Amanda, do you want to add to that?
Yeah, so I think, as Sam said, it's not, as I'm sure you all know, it's not about a single point in time in inspection. We can start an assessment and update ratings at any time, and there are a number of different ways that we'll collect that evidence. And this is, I suppose, this comes back down to the evidence categories, that there will be some evidence that we'll collect remotely. We'll request documents. We may conduct interviews either in person or on the phone. We may want to talk to some of the people using a service. We may want to come on site and observe care. So there is a whole different variety of ways that we'll be collecting and assessing evidence. And we'll be really clear when we start an assessment exactly what the information is that we're looking for that particular assessment, which may cover one, may cover two, may cover a number of different quality statements. But it's that fundamental point of, this isn't just about going on site and looking at and expecting to see lots of documents on site on the day.
Thanks, Amanda. So then we did also have a really popular comment suggesting that everyone would like details of the evidence expected, and this being the only way CQC will achieve a consistent approach. So that's really helpful feedback. The next question is, whistleblowing information can be vexatious. How will CQC validate this information before using it as part of the evidence? So I think Amanda, you kind of answered this a bit earlier, but is there anything else? Do we want to kind of just reinforce that point about looking to triangulate evidence at all points?
Yeah, I think that is the answer on this. That whilst obviously whistleblowing evidence could be of kind of fundamental importance, and we know from the past how much that can kind of open up and lead to some really important findings about a service. It is only part of the evidence that we look at, that we will weight all evidence categories equal, and as now there will be some triangulation across those different evidence categories.
Thanks, Amanda. We have had other questions about consistency, but I think we've already tried to answer that. We then do have a question about, do you have any resources, videos, pamphlets, etc., that trusts can disseminate to staff to help them understand the new framework and help prepare for an inspection under the new framework? So I think a couple of things I would say to this. I think what we're trying to do with the core guidance is make that as accessible and easy to understand as possible, so that becomes the first port of call for anyone trying to understand how we'll regulate. But we are very open to looking at producing supporting resources that sits alongside that. So one of the questions in the survey that we'll send out to attendees after this meeting is asking about what additional types of resources you'd find useful. So do let us know your thoughts on that, and if we hear from everyone that we need to produce a set of videos or something similar, that's something we can look at. So I'm conscious of time, and I don't want to keep colleagues longer than we advertised. Obviously, we haven't been able to get to everyone's comments or questions, but I just want to reassure you that we won't be losing all those. We'll take them away, and they'll inform how we produce and what new guidance we produce in the future, but also will help inform new webinar sessions in the future. And I think we've heard strongly around things like the scoring process, that people would value more information on that, for example. So that's something we'll take away and look at. I just wanted to end by reinforcing a couple of updates for colleagues that we'd previously shared. We have definitely heard loud and clear through sessions like this, but through other routes, that providers feel like you need more guidance before you feel ready for our new regulatory approach. So we've been doing a lot of work behind the scenes to get that ready. And even the next few weeks, we'll be publishing the remaining guidance that describes other elements of our approach that you've told us you need. We did share a few weeks ago that our intention is to start our new regulatory approach in the south. So there is information on our website that we'll share about what area of the country we mean by the south. And we'll be directly in touch with providers in that area with more information soon. And then also get in touch with providers in other parts of the country about when we're likely to start our new approach with them. We know we also get a lot of our questions about when our new provider portal is coming, and just want to reassure people that this is still launching and will be launching soon. We'll be inviting providers to join that at first, so look out for that arriving in your inbox if you're in the first group to be invited to join. And we're looking to deliver more webinars like this to explore other areas of our new approach. So we'll be looking at webinars that talk about how frequently we'll assess and what assessments will look and feel like, sessions on our new scoring approach and how we'll report following assessments. We know we need to provide more information about services, about our approach for services we don't provide ratings for, in particular dentists, and also on how our new factual accuracy process will work. So look out for dates for those webinars coming soon, and how you can sign up. And how do you find out that information? So there's a whole number of ways. Go and check out our digital engagement platform, Citizen Lab. There'll be surveys and other ways to feedback there, particularly to help us get the guidance right. If you don't already receive our provider bulletins, you can sign up to receive those on our website. We'll always share new information first through those bulletins, so it's really worth making sure you're receiving those. And you can also sign up to our Medium page to see new blogs from us. Also, make sure you're following us on social media. There's always information on there about new guidance and other elements of our new approach. And you can also sign up to listen to new podcasts coming soon. That's everything we wanted to cover today. Dave, Amanda, is there anything you wanted to end with before we finish?
Just to say thank you for so many people to sparing their time to come along today. Thank you.
Absolutely. Thank you again. We'll share the recording and the slides of today's session with everyone who's attended. The recording will also be posted on our YouTube channel, so you can share that with any colleagues who might be interested. We'll also share the survey to feedback on the guidance around quality statements in evidence categories. Do let us know if it's right for you or whether we need to provide additional information. And we'll also provide a survey so you can feedback on today's webinar session. We want to make sure these are the most useful sessions for you possible. So let us know how it's been and how we can make it better in the future. But yeah, a big thank you to everyone who's joined us, and we'll hopefully see you in future sessions.